So we are going to be learning about why the newborn is more vulnerable to infection, what are the types, how to identify the clinical presentation and the management. Right, so first thing is, why is the newborn more vulnerable? So they have less immunity. So they have less cellular immunity, meaning their polymorphonucleosides are immature. Similarly, they have immature monocytes, T cells, B cells, and natural killer cells. Their humoral immunity is also less, right? And especially if they are preterm babies, they are born before term. You can see most immunoglobulins are transferred during the last trimester. So if they are born preterm, many of these immunoglobulins will not be transmitted across the placenta. And their complement pathway also may be more immature, which puts them more at risk for gram-negative infection. And their barriers like skin is very fragile and can be easily damaged, right? So this is why the newborn is more vulnerable. And looking at this, you should understand that a preterm newborn is even more vulnerable than a baby born at term. Okay, so early infection is infection that occurs within the first 3 days or the first 72 hours. Whereas late infection is infection that occurs after these first 72 hours. Right. So early infection, we'll talk about early infection first. Right, so early infection is usually acquired from the mother. It can be either something coming through the placenta or an ascending infection from the cervix. And most commonly, it may occur in it may manifest in the first 6 hours of life, and almost all 80 to 90% will manifest within the first 24 to 48 hours. So what type of infections have been here? It has changed through time. You can see in the 1950s, it has been Staphylococcus and E. coli, right? So Staphylococcus, how does Staphylococcus infection spread? Dilini, what do you think? How does Staphylococcus infection, where is Staphylococcus? How does it spread?
It's a commensal on the skin, madam.
Well, some types of Staphylococcus. So what do you think? Why do you think there is not much Staphylococcus in 1990? What is the action that has sort of, brought about, what has changed this? Anyone? It is in the skin, you're correct. So something we have done, something we have got better at, might have changed the pattern of organisms from 1950 to 1990. Can anyone think what that is? No? Okay. So Staphylococcus is on the skin, right? So if we wash our hands, the chances of Staphylococcus being spread from healthcare workers or somebody else to a baby is less. So with improved hand washing, Staphylococcus has got better or less from 1950 to 1990. E. coli is again fecal-oral contamination, right? So the cleaner things are, the more if we do our procedures in a more hygienic manner, again the coliforms also get less. So with more and more development, the group B streptococcus is something that comes from the mother, becomes more predominant. Coliforms should become less with improved hygiene, but with equipment, plastic tubing, commensals like coagulative negative staph can occur. So you can see with time, the etiology kind of changes. Sorry. So what is the pathogenesis? How does this happen? What are the risk factors? right? So baby is in a sterile environment when it's covered by all the membranes. But if those membranes break, the baby is exposed to the outside, right? So prolonged rupture of membranes is a risk factor for infection in the baby. Similarly, if there is an infection on the membranes, maternal chorioamnionitis, right? Hopefully you remember one membrane is the chorion, another membrane is the amnion. So if there can be infection, then again, that is in close contact with the baby, it can cause a problem. So features that may suggest maternal chorioamnionitis include fetal tachycardia, uterine tenderness, fever more than 38, maternal tachycardia, foul-smelling lico. Again, maternal UTI, right? Because you know the urethral tract as well as the cervix or the entrance to the uterus is close by, and there can be ascending infection. The need for resuscitation at birth, maternal group B streptococcus, all these are risk factors for early onset infection, right? So what you have to remember is early onset infection is predominantly to do with maternal issues. Okay, someone has asked, what does prolonged rupture of membranes mean? It means the baby should be delivered soon after the membranes rupture. So the longer it takes, higher the risk, right? Some books say the risk is that there is a significant risk when it's more than 18 hours. Some say it is more than 24 hours, but usually we take the lower number. And if there is membrane rupture for more than 18 hours, it is taken as prolonged rupture. It is not the same as premature rupture. This can be a pregnancy at term, right? And usually soon after membranes rupture, baby is supposed to be born. But if they are not born, maybe we have done ARM and baby is still not born. So in that case, the longer the duration of membrane rupture. So significant increase in infection has been seen after 18 hours. That is why we are taking that cutoff. Is that clear? Any questions with regard to the prolonged membrane rupture?
Thank you, madam. Yes, it's clear.
Right? So when we are asking, when we are taking history in a baby who we suspect to have infection, we have to ask the mother what time did the membranes rupture, what time did she start dribbling, and calculate the time from that time to the time she delivers, right? So let's say it's 1 or 2 hours, the risk is minimal. So similarly, these other things, whether she had a UTI, has she had fever, is she on antibiotics, IV antibiotics, which might tell us that she's having chorioamnionitis, right? So whether previous children have been affected by group B streptococcus, because group B streptococcus is an organism in a women's birth canal, and it can cause problems from time to time, not to the woman, but to the babies. So then we come to late onset infection, right? So this is after day 4, and this is more than stuff coming from the mother. This may be like hospital acquired infection. So this is acquired from the caregiving environment. So then there are the various staph species, right? So we talked about that there's an increase in coagulase negative staphylococcus, especially with, let's say we are using so much of equipment to stabilize or to sustain life support for our very preterm and very small and sick babies, like CPAP tubing, umbilical venous catheters, long lines, so many plastic stuff. So in those plastic stuff, it can increase the risk of these staph species as well as fungus like Candida. In addition, they are at higher risk of getting gram-negative infections also from the environment, right? So there are many organisms like this, like Klebsiella, Pseudomonas, Enterobacter, Acinetobacter, that can cause problems. So late onset infection can occur through colonization, as I mentioned earlier, on vascular catheters or urinary catheters, on indwelling lines, maybe contact with caregivers who have bacterial colonization, as well as being exposed to prolonged antibiotic use. Because we know we have commensals which help to fight the bad bacteria. But by using even a single dose of antibiotic, we may kill all our commensals. So the longer we use antibiotic, less commensals we have, the more likely that we can be attacked by pathogenic bacteria from the hospital setting. So this is why it's very important that you pick your antibiotics wisely and have a very careful, strict control and stop them when needed. Judicious use of antibiotics. You should not just use antibiotics. Use it for the shortest duration recommended. So here what you can see is incidence of early and late onset invasive group B streptococcus disease from 1989 to 2000. You can see it has slowly come down. And there have been various things have happened. There have been statements, guidelines, consensus guidelines, right? So with more and more awareness, with more and better control measures, infections can be brought down. So then we come to the question, how do we identify a sick newborn? Okay. Can you tell me what, there are various tubes attached to this baby. Would you like to tell me what they are? Arul Janani, can you name some of the tubes that are attached to this baby?
Nasogastric tube.
Sorry? Nasogastric tube. Yeah, okay, good. Anything else?
Monitoring ECG.
Okay, ECG leads, all right. What else?
Cannula.
Cannula, yes. Is that all? Let's see. Okay, cannula is connected to a two-way. Yeah, pretty much that's it. Okay, so then signs and symptoms of infection or sepsis in a newborn is very non-specific. That is the problem with newborns. Yeah, anything can, their symptoms can mean anything. All we have to know is that something is not right. So they may have temperature irregularity. Either they can have fever or they may get cold with hypothermia. Then they may have issues with tone and behavior, like either a very high-pitched cry or a weak cry, or irritable or lethargy or poor tone or bulging fontanelle. Their skin may be mottled. They may have cyanosis, pallor, petechiae, or unexplained jaundice, right? So all these are non-specific symptoms that we see in a baby. So it can be very vague, like the color is not right, baby is not as active as usual, baby is either cold or baby has got a fever. It can be either way. Baby is very irritable or baby is very lethargic, not wanting to feed. There may be features of skin bleeds like petechiae, or a funny color which is like jaundice. So any of these things, inappropriate color, inappropriate behavior, or alterations in the temperature can mean that the baby is having an infection. Again, similarly, there can be feeding problems like vomiting, diarrhea, almost anything, hypoglycemia, abdominal distension. Then cardiopulmonary features like increased respiratory rate, retractions, that is chest indrawing, increased heart rate, decreased blood pressure, low saturation. So any of these things can mean that the baby is affected by an infection. So we talked about, when we talk about infection in babies, you must remember early versus late, because the causes are different, organisms are different. Therefore, we should treat it with different antibiotics. Our approach is different, right? So early infection is usually related to maybe stuff in the mom, and late infection is usually related to stuff from the hospital, right? So, okay, Brahman, can you remember what is early infection? Within how many days or within how many hours?
Within first 4 days.
Oh, within first 3 days, right? Within the first 72 hours. Okay, good. And late infection is 4th day onward, right? So early infection can come in the form of either skin infection, like pustules, or umbilical cord infection, which we call omphalitis, can be eye infection, conjunctivitis, or it can come as pneumonia. That is the most common invasive early infection, right? The others are on the mucous membrane or on the skin, or it's are kind of outside the body. But the commonest invasive early infection is pneumonia. Whereas if you look at late infection, meningitis and septicemia is more like common. Okay. Right. Vitanage, what do you think of this picture? This is a newborn baby skin. What are you seeing here? Vitanage, LH.
Madam, pustules are there?
Yes, very good. So you can see like blisters, but they are little yellow colored. They are surrounded by a red margin. This is what pustules look like, right? If you remember, erythema toxicum is different. They are like a red patch with like a pinpoint head of yellow in the middle. So these are pustules. What is the organism? Tarindu, Dhanavardhana, what is the organism you think is responsible for these pustules?
Staphylococcus.
Okay.
Streptococcus.
Staphylococcus what? Staphylococcus aureus, right? Okay.
Aureus.
Yes. So do you want to treat this, or shall we just wait without treating it? What do you think should be done? TMW Gunavardhana? Should we treat this or should we ignore it?
Treat, madam.
Treat. Very good. Now, how do you propose we treat? So we know these are pustules. We know it is caused by Staphylococcus. How do you think we should treat? It's okay if you are not absolutely correct. I want you to think and answer.
IV antibiotics.
Okay. What if there are few pustules only? Like if it's 1 or 2? But if you get a pimple and it gets infected, IV antibiotics done, right? But if there are lots like in this baby, in this picture, yes, I agree, you may need IV antibiotics. Okay. What else do we need to do? We said it's in the skin, and by hand washing we can prevent. So what else do we need to do? Other than antibiotics? Antibiotics is correct. We'll look at how we decide on the route. What else? Other than antibiotics, one more thing we have to do. We know we are getting it from the skin. So do you think washing the baby matters? Oops, what did I do? Jordan.
Yes, madam.
Yeah, do you think washing the baby or advising on how frequently the baby should have a bath, do you think it will help?
Yes, madam.
Yes, so how would you advise? Daily baths, once in 3 days, once a week, couple of times? Yeah,
2 times a day.
2 times
A day.
a week or a day?
A day, madam.
Good. Right. So skin infection is caused by Staphylococcus. We should advise baths at least once a day, right? If they are willing to do it 2 times a day, fantastic. So, but we should not bathe the baby before 24 hours because they get cold. But after 24 hours, a baby can be bathed, and it's recommended to bathe them every day, at least once. Twice is absolutely fine. So if there are only few lesions, let's say if there are less than 10 lesions, right, and none of them are very big, they are small lesions, we can use local application, right? Can someone tell me what any local application you know? Janita, any local application you know which can work against Staphylococcus? Janita, Manoj?
Local.
Fusidic acid, right?
QCD. Yeah.
Yeah. So you can use fusidic acid local application. Thank you. Okay, Tusal, can you think of an oral antibiotic? So if there are more than 10 lesions, but the baby is very well, we can actually try oral antibiotics. But if there are many lesions, we should admit the baby so we can monitor. Tusal, what is the oral antibiotic we can use, which you think will work for Staphylococcus? Use your knowledge on pharmacology. You must have learned this in your foundation module or under IPD.
A kind of penicillin, madam. Like.
Okay. Penicillin. Can you believe it? Yeah, it is a kind of penicillin, I suppose. What is the type of penicillin?
Amoxicillin.
Amoxicillin. Okay, but there are things that work better against staph, right? Anyone else wants to help?
Staphylococcus penicillins, cloxacillin, flucloxacillin.
Yes, cloxacillin, you're right. It's a penicillin, but usually cloxacillin and flucloxacillin would work well for staphylococcus, right? So if there are a lot of lesions and the baby is well, we can start oral antibiotics. We have to admit the baby though. We have to admit the baby and start oral antibiotics and see. So oral cloxacillin or oral flucloxacillin. If the baby is sick, as in baby is either febrile or systemically unwell, either irritable or lethargic or something is wrong, right? Then we have to start intravenous antibiotics. So Nishadi, what are the intravenous antibiotics you would choose? Like, let's say like the picture I showed you and the baby is sick. Or we start oral antibiotics and it's not improving and the lesions are getting worse. In such situations, we have to move to IV. Nishadi Gunasinghe, yeah. What IV antibiotics will you use? It's easy for you. Now we already mentioned the oral antibiotic. What are the IV antibiotics that would work against, what is the first line against Staphylococcus infection? If you are to give IV antibiotic. No idea? Anyone else? What are the IV, first line IV antibiotics we can use against Staphylococcus? Tejan Gunasekara?
Nafcillin.
Sorry. You guys have learned this now? What antibiotics work for which organism? Why are you finding it so difficult? What are the antibiotics that works against Staphylococcus? Now, a previous person told also the correct answer. What were the antibiotics that work against Staphylococcus? If you were listening, you would have heard.
Cloxacillin and flucloxacillin, madam.
Yes, cloxacillin and flucloxacillin. So same thing you give IV. No change. If the baby is well, you can give oral. If the baby is not improving, you change to IV. That is why we are admitting. If the baby is sick, at the time we are seeing if the baby is not looking well, if any of those non-specific symptoms are there, then we have to give IV, either cloxacillin or flucloxacillin, right? It's the same antibiotic, but the route is different. Okay. So you need to know if you see pustules that it is an infection. It is not a benign skin lesion. Right? And therefore it needs treatment. And since it is by skin contamination, it needs daily baths. Just a minute. And it needs antibiotics that can tackle staphylococcus, right? Which is either cloxacillin, flucloxacillin, fusidic acid. So local application is with something like fusidic acid. Oral is either cloxacillin, flucloxacillin. IV is also cloxacillin, flucloxacillin. Same antibiotic, but the route will change if the baby is sick or not responding to oral. Right? So how do you prevent? By washing hands. So you must never touch a baby or any patient for that matter without washing your hands. You must now these days with the COVID, I'm sure everyone learned to wash their hands and not to touch unnecessarily. So minimal handling and hand hygiene. Okay. Chulakshi, what do you think about this umbilicus? Do you think this is healthy? Or do you, yeah?
It seems healthy, madam.
Very good. Why are you saying it's healthy? Can you tell us?
Because, madam, if there is no pus or blood or periumbilical erythema surrounding the umbilicus, which can be considered as dangerous.
Yes, very good. Thank you. So spot on, right? So there is no pus, there is no blood, and there is no periumbilical erythema, which makes it look healthy. Okay, Nuanta, what do you think about this picture? Do you think this is also healthy like the previous one, or do you think this is different? And why, if you think it's different?
Madam, it's different from the first one. It's red and inflamed.
Yeah, where is the redness? Can you describe?
Periumbilical region is inflamed.
Yes, very good. So this is, you can see a periumbilical erythema. This is not a healthy umbilicus. Let's look at some more pictures. Gayani, Vijay Singha, what do you think about these two?
On the first picture, madam, there's a discharge coming out of the umbilicus.
Yes.
And
What
on the
color,
second,
what color discharge is it?
sorry, madam,
What color? What do you think the discharge is?
yellowish color, so maybe pus.
Yeah, that is like, it looks like a purulent discharge, isn't it?
Yeah.
Right.
Yeah.
Okay. And the second picture?
The second one is the red color discharge, so I suppose that
It
can
might
be
be,
blood.
but it can be blood. Yeah. So these are your three danger signs, right? The periumbilical erythema, the pus and blood. So neither of these umbilicuses are healthy. What do we do if we see these danger signs? Should we like give some ointment to put fusidic acid ගන්න කියලා ගෙදර අරිනවද, or should we do something else? You may see these patients in your general practice. Vimalasena, what should we do? Should we just local application? Do you think is it enough, or do we need to do anything else? Okay, so here you can also see another horrible looking umbilicus. There is lots of erythema, it's inflamed, looks very unhealthy, right? And so you your colleague named the danger signs very well: pus, blood, umbilical erythema. So if you see any of these danger signs in the umbilicus, you have to treat it with systemic antibiotics, right? No local application. Please don't put local application and send it back. You have to treat it with systemic antibiotics. Okay, Naomi, what can you see here? Focus on the baby's eye.
Yellowish discolor, yellowish discharge.
Okay, is it only yellowish discharge? What else? Yellowish discharge is correct.
Erythema around the eye.
Yes, what else?
And the periorbital edema.
Very good. There is swelling also, no? From what we can see, it's swollen, red, and there is purulent discharge. Right. So there seems to be signs of inflammation. So, okay. So what do you think this is? Sashi Vikramarachi? Do you think there is an infection going on, or do you think this is a physiological eye discharge?
Madam, I think it's due to an infection.
Okay. Why? What are these signs? These are signs of what?
Acute inflammation.
Very good. These are signs of acute inflammation, right? And if it's a physiological discharge, there is no way that these things should be there. So this looks like an infection. But the other thing you need to know is newborns do have physiological eye discharge. Okay, so that in that case, the eye will not be swollen, eye will not be red, the discharge will not be yellow. It will just look like tears, but the eye will look healthy, and that is due to blockage of the nasolacrimal duct. Right, so unilateral eye discharge in a newborn, in a otherwise well healthy looking eye, is physiological. But here you have to differentiate. So in that there is no antibiotic needed if there is no redness, swelling, no pus, nothing. Right? All you do is you just massage a little with your little finger, the internal angle of the eye. But here, with all these signs of acute inflammation, this is definitely an infection. So what do you think the organism is, and how should we treat this? Suganya? Suganya, what do you think is, what is the responsible organism? So it's on the skin, right? Yeah, so think.
Staphylococcus.
Yes, again it is staphylococcus. So what, now think this is the eye. So what can we use to treat this eye infection? It can be staphylococcus, or there can be other organisms as well. How would you name this infection? What do you think this infection is? Is it a conjunctivitis, or is it something more? Have you all done the special senses module and the eye? Or you may have done the eye appointment.
The periorbital cellulitis.
Yes, very good. Periorbital cellulitis. Hi, sorry, I think I got disconnected. Can you hear me and see the screen?
Yes, madam. I can hear you.
Yeah, okay. So I think one of your Kirutikan mentioned is periorbital cellulitis. That is correct. And if so, it is a very serious infection. So we have to start with IV antibiotics, right? So in addition to Staphylococcus, Haemophilus influenza is one of the important organisms that you have to think of, which causes periorbital cellulitis. And it can sort of from the orbital cavity spread to the cavernous sinus and cause a lot of problems, even a meningitis or cavernous sinus thrombosis. So immediate antibiotics are necessary and they should be intravenous, right? Right. What about this eye? Let's see. Rasari, Guru Singha, what do you think about this eye? Do you think this is healthy or do you think there's an infection? And if so, what? And what are the features that we can see?
There's no redness or erythema around the eye.
Yeah.
So this can be like physiological, like Madam mentioned before.
What about inside the eye, Rasari? Can you see like a purulent discharge inside the eye, like pus-like stuff inside, and the eye has got a little small? True, we can't see the inside. We
Yeah.
can't see the conjunctiva, but you can see a purulent discharge, no?
Yeah.
Yeah. So this is like, if it's a physiological eye discharge, then it will be like tears, like watercolor. No color. Since there is pus here, this is more like a conjunctivitis. How this is different from the previous one is here the swelling around the eye is minimal. As you mentioned, right? Around the eye, there is not much redness, not much swelling. So this is unlikely to be a periorbital cellulitis. And this is more likely to be a conjunctivitis. That is a less serious infection, but still it is an infection. Right, and the commonest organism causing conjunctivitis in the newborn is who? Binoli, what do you think is the commonest organism which causes conjunctivitis in the newborn? Tarindu, yeah. What do you think is the commonest organism that causes conjunctivitis in the newborn?
Madam, I'm not sure about newborn, but I think usually conjunctivitis is caused by adenovirus.
In newborns, yeah, why? That is because we go out and all. No, newborns don't go out by themselves. So in newborns, again, commonest cause is staph, right? It's staphylococcus that causes conjunctivitis in newborns. So in such case, we have to use again antibiotics that are effective against staphylococcus. So do you know any eye drops or eye ointment that can be used? Sulakshana? What sort of eye drops can be used? Sulakshana Murugadas?
Yes, madam. I don't know, madam.
You don't know? Try to remember. Have you not done eye appointment or eye module? Not eye module, special sensors or special, I don't know what you call it. You all have no special sensors module? You should have done, no? Isn't this the last module on the list? Reproductive health. What are the eye drops you know? Do you know the name of any eye drops, Sulakshana? Any antibiotic eye drops? No? Okay, does anyone else know any names of any antibiotic eye drops? I'm sure you have learned conjunctivitis in your special sensors module.
Madam, chloramphenicol?
Yes, good. Chloramphenicol you can use. Anything else? So we use that. That's like our first line. What else? Gentamicin. There are different eye drops. Okay, good. Can someone tell me the difference between eye drops and eye ointment and the clinical implication? Akhta? Akhta, can you tell us the difference between eye drops and eye ointment?
Madam, eye drops are like dropped on the conjunctiva, madam. Eye ointment, I'm not sure, madam.
Both you put on the conjunctiva, but what about the frequency? Are they both put in the same frequency, eye drops and eye ointment? Anyone? So eye drops are very watery, right? They get washed off in 1 or 2 hours. So you have to put eye drops every 2 hours or so with a severe infection. Whereas ointment is on an oily base, it stays inside the eye for a much longer period of time. So if you are prescribing, you need to know these things, otherwise it's not going to work. If you are prescribing eye drops, they should be prescribed every 2 hourly, right? And if you are prescribing 4 hourly, depending on how severe the infection is, both you have to put inside the conjunctiva. If you are prescribing eye ointment, that lasts for a long time because of the oily base, and that you have to put only twice or thrice a day. Okay, so conjunctivitis is commonly caused by staphylococcus, right? And before we start antibiotics, we have to take a eye swab for culture ABST. So we treat with local antibiotics if it's only a conjunctivitis, like we saw in the second picture. We can use eye drops or eye ointment. As we mentioned, we can use some
Recording in progress.
Okay, got disconnected again. Seems to be, I don't know, maybe the Zoom thing is getting overloaded. Right, so intravenous antibiotics is used for periorbital cellulitis, whereas the local antibiotics should be used for the conjunctivitis. And periorbital cellulitis is commonly caused by Haemophilus influenzae. So the intravenous antibiotic you should use is something like cefotaxime or ceftriaxone. Okay, so now we are going to move on to invasive infection. We looked at pustules, we looked at conjunctivitis, and we looked at one more thing, right, which was non-invasive. And now we are going to move into invasive infection, right? So invasive early infection. What can you see in this picture? Laksujan Jayakumar, what can you see in this picture? Focus on the child's chest. Laksujan. Okay. Can you hear me?
Yes, madam, we can hear you.
Can hear me, no? Right. Can anyone tell me what you can see on the chest? Right here, you can see a recession, right? There is chest indrawing here. Okay, let's look at the next picture. Right here again, you can see, if you focus on the side of the chest, you can see the skin is going in between the ribs. That is called chest indrawing. Right here, this is, or recessions. These are called chest indrawing or recessions. Here you can see a chest x-ray with some haziness on the right side more than the left side, which is suggestive of a congenital pneumonia. Right? So that is a feature of a early infection but invasive, which we mentioned the commonest is pneumonia. So what is the definition of sepsis? Sepsis is suspected or documented infection. Right? Suspected or documented infection in the presence of a life-threatening organ dysfunction by a dysregulated host response, right? So it's life-threatening organ dysfunction by a dysregulated host response due to which was caused by suspected or documented infection. So this is what we mean by sepsis. So again, the signs and symptoms of sepsis is non-specific, as we talked about earlier. So different behavior, fast breathing, change in skin color, change in tone, feeding difficulties, abnormal temperature, all these are symptoms and signs of sepsis. So how do we identify invasive infection? It should be the first line of thought in an unwell baby, because we said symptoms are very non-specific. And since they are very non-specific, there is a lot of mortality, 50% mortality. So we have to have a very high index of suspicion. We have to treat aggressively, start antibiotics after blood is taken for culture. Right? We don't wait for the culture results. We anticipate and treat complications. So there are a couple of things we have to think of. If a baby is not acting well, baby is unusual, not behaving as usual, if the baby is lethargic, few things. You have to see whether the baby is cold. You have to check the temperature. You have to see whether the baby is having a hypoglycemia, which we talked about, right? When we talked about baby of diabetic mother. So you have to check blood sugar, capillary blood sugar. And then you have to see if that you get the results spontaneously in both those things. You measure the temperature. If the temperature is normal, or even if it is abnormal, if the blood sugar is low, it may be those, plus or minus, whether the baby is well in between. So once you correct the temperature and once you correct the blood sugar, if the baby is still not doing well, then it's very likely that the baby is suffering an infection, and infection resulted in both hypothermia and hypoglycemia. So in this case, we have to take blood for full blood count, CRP, blood culture, and then start antibiotics. So what are the investigations that we do? We should do a full blood count. The white cell count may be either high or low. So it may be more than 35,000 or less than 5,000. Platelet count may be less than 100,000. CRP may be normal initially if you do it soon after birth because it takes 6 to 8 hours to increase and it peaks after 24 hours. So blood culture needs to be done, but we must make sure that we take, to see the blood culture broth is usually 1 in 10 dilution. So we have to try and take at least 0.5 ml. Because for neonates, there are small blood culture bottles, but which have a broth about 10 ml. So we have to try and put 1 ml for the best dilution, but at least 0.5 ml. Then swab cultures like umbilical swab, deep ear swab, right? Soon after birth, if we get the baby, we can do swab cultures to see whether what sort of colonization is there on the skin. Then chest x-ray for respiratory symptoms. CSF we do if the blood culture is positive or if there are signs and symptoms suggestive of meningitis. Then we have to treat the baby. Right, supportive management, supporting the airway breathing circulation, as well as support with antibiotics. So we have to start antibiotics immediately after obtaining cultures. For early onset infection, we said group B streptococcus and E. coli are the commonest organisms, right? So group B streptococcus is sensitive to crystalline penicillin, whereas Escherichia coli is sensitive to gentamicin. So that is why these two, penicillin and gentamicin, are the first line antibiotics universally for neonatal infection, early neonatal infection. Late neonatal infection, we said the organisms are different, right? So we said there can be variety of staph, there can be gram negatives, and there may be fungus, right? So initially we have to cover for the staphylococcus as well as the gram negative. So we have to give a broad spectrum antibiotic that covers both of them. If they don't respond, we have to look at the unit, what sort of cultures we have had in the unit, and then change the antibiotic. So also when we get back the ABST, we can change the antibiotic depending on whether the baby is responding or not. So how long should we give these antibiotics for? So we have to give until the baby is clinically well and the blood culture is negative, right? So there is no fixed number of days. But in the case of meningitis, we have to give for 2 weeks because it's difficult for us to be doing lumbar punctures again and again, and it may be harmful for the child to see whether the lumbar puncture has cleared, CSF has cleared. So we give 2 weeks of antibiotics for a gram-positive meningitis like a group B streptococcus meningitis, and 3 weeks for a gram-negative meningitis. So prognosis, the mortality is more than 50% if you miss sepsis, right? Or late diagnosis, if you miss, it might be 100% actually. So it results in a lot of neonatal deaths. 1/3 may have abnormal neurological outcomes if the diagnosis is delayed or missed. And smaller babies and gram-negative infections are associated with adverse outcomes. So these babies have to be followed up. These are high-risk babies. They have to be followed up both in the tertiary care center as well as in the community, not only in the community. And we have to follow them up with regard to growth, abnormal neurology, whether they are getting development delays. You may remember we talked about development delays and we talked about the stormy neonatal period, right, during your PBL on abnormal development. So these are things that can happen. And there can be abnormalities of head growth because of either hydrocephalus or microcephaly. So it's important to monitor the head growth as well. Right, so these are serious, especially if there's an invasive infection. These babies need follow-up if they have had a blood culture positive infection. Okay, I think that's it. Any questions? I think time is up as well, but I can answer a quick question if there is one.
Madam, sorry.
Yeah. Go ahead.
Okay, madam, the picture on conjunctivitis, madam, is that similar to ophthalmia neonatarum or is it a different
Ophthalmia, yeah, good question. Ophthalmia neonatarum actually means eye discharge in the baby. Right? So it means anything. So yeah, it is similar to that. And under that, it is not one disease, like it's basically saying eye discharge in the baby. So it can be ophthalmia neonatarum covers staph conjunctivitis as well as it will cover the chlamydial conjunctivitis as well, which are not common.
Okay, madam, thank you.
Okay.
Madam, what does periumbilical erythema indicate?
Systemic infection.
Okay,
It comes,
thank you.
I don't know why it gets red there. I don't know why it gets red there, but if it is there, it indicates systemic infection. So that's why you shouldn't, like, anything in the umbilicus, don't put cream and send back. Admit them and we will need to give them systemic antibiotics most of the time.
Thank you, madam.
Okay. I'm happy
Madam.
there are questions. Yes. Go on.
Yes, madam. In sepsis, we give IV penicillin and gentamicin. Do we give
early
it?
sepsis, Sakta. So that is if they manifest during the first 3 days usually.
Yes, madam. So
Yes.
we start that empirically and then we can give specific treatment if the culture report arrives.
That's right. So when we are now, because we said it's very non-specific, no? So even if the baby is not looking right, not feeding well, looking lethargic, any of those non-specific things, if we can't explain them by, say, hypothermia or hypoglycemia, next thing we think is sepsis. So we take all the bloods, put the cannula, give the antibiotic. Then later only the blood culture will come, the CRP will come. And so looking at that only we can diagnose. Yes, so before we actually have a definitive diagnosis, we start treatment. Especially if the baby is sick. In marginal cases, you can look at wait for the CRP and see. But definitely you don't wait for the culture because CRP you can get in about an hour or so. But if the baby is sick, don't even wait for that. Take the bloods and start the antibiotics. And when the culture comes, yeah, you refine. And as you mentioned, we can look at the ABST and refine our antibiotics.
Okay, madam.
Thank you. Those are very good questions. Anything else? Pulasi, there was a question which I missed because I think I got disconnected. Yes, what
Madam,
was the question? Sorry, I forgot.
Madam, in that skin infection, what happens if the pustules rupture while washing?
Nothing.
No problem.
No problem.
Okay.
We don't have to go and rupture it, but if it ruptures, no problem. Because like say even for abscess, like you had to do the IND and actually take the pus off. So nothing happens really. Anything else? Okay, I think yeah, I should end because like I'm 4 minutes over time. Thank you everyone for participating. So I'll see you again tomorrow. I think some of you for the PBL and Wednesday for something else. Okay, thank you.
Thank you, madam.
Okay.
Thank you, madam.
All right. Thank you.
Recording stopped.